Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
73-year-old never smoker with stage 4 adeno, right lung, brain, liver, and bone metastases, and treated with palliative radiation to the brain and spine, then received osimertinib in February of 2020. Now with progressing disease, PDL1 is negative, and a liquid biopsy has in the recent past shown exon 19. BRAF V600E has also been detected. Cough, performance status is good though, and type 2 diabetes, hyperlipidemia, pulmonary emboli at diagnosis. We have essentially brain lesions, had received radiation, has had an initial response to osimertinib. And here you can see the course of the pathology, essentially that the biopsy, liquid biopsy, has shown exon 19 mutation, BRAF V600E later detected. And that's what we have in the setting of metastatic disease. We have radiation to a few sites, brain lesions, cyberknife to T6, and more recently SBRT to a liver lesion. So now progressing on osimertinib, I know, Ram, you spend a lot of your time seeing and thinking about these folks. What would you recommend in the setting of a BRAF V600E mutation, but obviously we have chemo and immunotherapy options?
Yes. So there are a lot of interesting features about this patient. One is the patient presented with multiple brain mets, which were controlled with local therapy and with osimertinib. And then when you follow the ctDNA pattern of this patient never cleared the EGFR mutation from plasma. And we know that patients who have baseline detectable ctDNA, if they have persistence after 3 to 6 weeks of EGFR TKI therapy, their outcomes are not quite as good as patients who have clearance of the ctDNA. So I'm not surprised that 12 months later, this patient has experienced disease progression. Now, the big question is the BRAF V600E mutation a mechanism of acquired resistance for this patient? I tend not to think, because this was seen quite early on in the course of treatment. So this may be a concomitant event that the patient had even at the time the disease was diagnosed. So directly targeting the BRAF V600E at this point is not something I would consider, but I would definitely think about this a bit down the road. For now, this patient's brain lesions are under control, which tells me that continuing on with osimertinib is relevant in this situation, no matter what we do next. And my view would be to add chemotherapy, carboplatin, pemetrexed, and continue on with osimertinib as the next line of therapy. I'm not in favor of adding immunotherapy to the mix for two reasons. One is OC and immunotherapy do not mix well. And number two, we still don't have good evidence that immunotherapy plus chemo in this situation works very well. If one were to use immunotherapy, the only setting where we have some supportive data is using chemo plus Bev plus atezolizumab. And that also was based on a subset analysis from a prospective phase 3 trial in the frontline setting. So my approach for this patient would be continue OC, add carboplatin pemetrexed for now.
And I would say that I really agree with all of that. I think that BRAF V600E is not as likely to be the driver. It might be something to try subsequently, but would not supersede chemo-based treatment. I think the biggest question is, do you want to have the option of chemoimmuno, or would you prioritize the continuing osimertinib? And I agree, particularly in someone with brain metastases, especially more than one, that you would want to, if you can get it covered, retain the control that you'd hope to get in the CNS with osimertinib, though we don't have enough data. So, Cliff, anything to add on the radiation front here? I presume that, and if it's a very finite number of metastases in someone with a driver mutation, you would be judicious in favor SRS over whole brain.
Yeah, in general, the field is shifting more towards upfront SRS as our technology improves and it becomes easier on patients. And there certainly are, known cognitive effects of whole brain, albeit you can minimize that with some modern techniques. But on the brain in particular, I think this is something that can't be emphasized enough. The historic nihilism with these patients with brain mets was such that they would get some treatment and then we wouldn't image them again. And then as the systemic therapy agents have continued to improve, it becomes fundamentally even more important. So for example, this patient has a pontine lesion. At some point, it's going to escape control. Not if, but when, right? And so the question, if you stay on top of it, then salvage SRS can often prevent these patients from getting into real trouble and then allow the otherwise effective systemic therapy to continue. So I do think a close care with the brain metastasis team is important.
So to summarize for this particular patient, we would consider the BRAF V600E mutation potentially clinically relevant, but not likely enough to make it the next treatment approach. We would favor chemotherapy, and we would favor having him stay on osimertinib if that's possible, considering that more important than adding immunotherapy along with the chemotherapy. The chemotherapy, potentially, probably our leading choice would be a platinum and pemetrexed-based regimen along with the osimertinib. And the need to monitor the brain attentively, knowing that that's an unforgiving area that could be addressed with local therapy again as needed, but also knowing that osimertinib remains, even in the face of progression, the best way to control against progression in the brain.